Everyone, and welcome to our Atlantic Canada PKD Patient Forum. My name is Michelle Lynn Goodfellow, and I am the Communications and Engagement Manager for the PKD Foundation of Canada, which is the only national organization solely dedicated to fighting PKD through research, education, advocacy, support, and awareness. This session is presented by nephrologist Stephen Soroka with a patient story from Brenda MacKenzie. It was originally recorded in the opposite order, with Brenda's stories first and Dr. Soroka's presentation second, but we've rearranged the order of the sessions so that nephrologist's presentation is first. So you may occasionally hear the speakers reference information that came earlier or later in the original presentation. Dr. Stephen D. Soroka is a professor of medicine at Dalhousie University and a nephrologist in the Department of Medicine within the Nova Scotia Health. He received his medical degree at the University of Saskatchewan in 1990. He has several leadership positions at various levels of healthcare system. He was a medical advisor to the Nova Scotia Provincial Renal Program, physician lead of the Capital District Renal Program, VP of Medicine for Capital Health, and the executive medical director of the Central Zone of the Nova Scotia Health Authority. He was also the medical director of nephrology clinical trials for 12 years. He was a medical advisor to the Nova Scotia chapter of the Kidney Foundation from 2006 to 2012. Dr. Soroka has been a surveyor for Accreditation Canada since 2008 and the senior medical director of the Nova Scotia Health Authority Renal Program and Pharmacy Services since 2016. In 2022, he was acknowledged as a patient safety leader champion and was the recipient of the Nova Scotia Health 2022 Making Waves Award Program Leadership Excellence Award, Physician Leader. In March 2023, he was also awarded the Queen Elizabeth II Platinum Jubilee Medal for Nova Scotia. We'll now start with Dr. Soroka's presentation.
Thank you, everyone, and thank you, Brenda. I was privileged enough to have Brenda as a patient of mine for a while, as she's talked about, and I've been in practice for 28 years, and I would say my first experience with autosomal dominant polycystic kidney disease was actually before I started, when I was still in training in Edmonton, and I looked after a professional woman in her 40s who started on peritoneal dialysis because of the end-stage kidney from PKD, and then her mother actually didn't need to start on dialysis until she was in her 70s. And even though they obviously had the same genetic mutation causing their polycystic kidney disease, it just really reinforced in me the variability it can take within different family members. So this is a slide deck here that was put together for previous patient forums on ADPKD. I'm going to go through it and hit some of the highlights. And I guess the good thing is that the slides would be available for people to go back and review at their leisure afterwards. And so again, we know that this is an inherited disease with a prevalence of around 1 in 500. Although sometimes about 10% are spontaneous new genetic mutations in one of the two polycystin genes that are known. And the kidneys get multiple cysts, which make the kidneys grow big. And then when the kidneys start growing big, the cysts crowd out the normal kidney tissue, which then causes the normal kidney to start showing a decline in function enough, and then ending up in kidney failure or end-stage kidney disease. And some of the signs can be relatively, non-specific, although high blood pressure early on could be one of them. If you have a cyst that ruptures, you can get blood in the urine. You could have this feeling of heaviness or pain because there's large kidneys. You can have a kidney tract infection. You can even have kidney stones that can form. And, as we've heard from Brenda and her brother, even though the mother was known to have polycystic kidney disease, some people do not actually find out until they're in their 30s, 40s, 50s, 60s. And you can imagine with healthcare in the past, when family members who might have been mildly affected, they may have not been even diagnosed and passed on, and then their children might not even know if there was a family history or not. So obviously family history and symptoms, and then of course the ultrasound or the use of ultrasound more and more frequently actually has resulted in earlier detection and even diagnosis of polycystic kidney disease. And we also know that there are two major genes. There's been a third one, and probably more that will be discovered in time, that cause autosomal dominant, or ADPKD as I'll call it. The most common type is the ADPKD1, which is around 85%, and then the PKD2, which is the remainder. And what we know that the PKD1s are actually more likely to have a faster, earlier decline of kidney function, meaning they're going to need to be transplant or dialysis at an earlier age than those with type 2 ADPKD. And we also know, because it's autosomal dominant, if you have one parent that's affected, each child has a 50-50 chance of getting the same ADPKD. So within a family of four, you could have 1 to 4, or even no children or siblings that have ADPKD, all depending on sort of that 50-50 roll of the dice, which happens with every child. We talk about screening and why to get screened and why not to get screened. And this could be a whole hour just in itself, because obviously, if you know that you have PKD earlier, you can kind of be looked after, you can be, managed in a little different way. But on the con side, there's lots of problems around the psychological burden of knowing this. Certainly lots of concerns over getting healthcare insurance, all of that sort of stuff. And even if you start screening very, very early, unless you're doing genetic studies, you actually have to wait until about at least the minimum age of 30 by screening by ultrasound or MRI to really exclude that you don't have it. So we'll talk a little bit about that later. But genetic testing, again, would be the definitive diagnosis if you have a gene mutation that has actually been found already, because there are new ones. And the genes, the polycystin genes, are very, very large genes, and there's 200, 300 different mutations that can cause either type 1 or type 2 ADPKD. Genetic testing was also very expensive. It was hard to get to. In Nova Scotia, we send people to the genetics people at the IWK, but the wait time can sometimes used to be up to 2 to 3 years, if not longer. Now it's a little bit shorter. And then the other thing that's happened is they've got rapid sequence gene testing, which can be, they can do a multiple number of genes a lot quicker, and the cost is coming down. So we do expect that we will see more and more genetic testing happening in the future. So you don't need to have a genetic test for ADPKD, but there are some situations where you really want to have the genetic testing. And that for sure is going to be if someone like Brenda or her brother was looking for a living kidney donor, and one of the family came forward from a niece or a nephew or somebody, you'd really, if they were younger and they didn't have any cysts on ultrasound, you'd really want to do genetic testing. And we do that for the transplant program to ensure that they are truly not polycystic. We can also do it to identify mutations, exclude other things, and particularly if the picture, the picture of the polycystic is a little bit in question, and obviously someone who wants to have a child and is worried that the child may be polycystic, you can use it as for prenatal or even pre-implantation diagnosis of polycystic kidney disease. Again, I've talked about the type 1 and the type 2, and we know again that the type 1 people will have a more accelerated decline of kidney function, leading to kidney replacement therapy, whether it's dialysis or transplant in an early age, than in the people with type 2. It's interesting that it's called polycystic kidney disease, because that's what the first manifestation would have looked like. But because it's thought to be related to something involving connective tissue around the body, there are multiple other things that can present in people with polycystic kidney disease. And so we talked about the kidney-related stuff that's on the left side of the slide, but then there's all the non-kidney related. So brain aneurysms, heart valve problems, cysts in the liver, hernias, diverticular disease in the colon, and even cysts in other organs like ovaries, et cetera, et cetera, et cetera. So, it really is a true systemic can affect a lot of areas of the body, not just the kidneys themselves. And, you know, I would say the PKD Foundation has a wonderful website, and there's lots of videos and things there for information. So it really is the go-to place if you're looking for more answers to questions you might be having and just general information. And if you go to the kidney website, this is sort of, you know, when you're newly diagnosed, all of the questions you might have, and for the answers to them, they are actually on the PKD website. So we'll jump into this, you know, the management, you know, it's like everything else. There's a management of ADPKD itself, and then there's a management of complications. And it's diet, exercise, water intake, medications, and then all the complications like kidney stones and liver cysts and, you know, aneurysms in the brain. Obviously, follow a healthy diet, do some activity, but, you know, don't do anything that might be involved like blunt trauma, because you can have a rupture of a kidney cyst. Taking in a reasonable amount of water. We have become a water culture the last number of years, not so much 10 years ago, but you see people carrying around these big 2 and 3 liter or gallon jugs of water everywhere they go now. So that's not a bad thing. And when it came to the research around anything that would be useful in treating polycystic kidney disease, it was back in '95 when I just started my practice in Edmonton that the genes had been identified. And then it took how many years until we actually had a trial back in 2012. And in fact, we were a center in Nova Scotia. We started back in 2008. So I have some of my patients that have been on this GnRH or Tolvaptan all the way from 2008 all the way through, and some of them still are on it, although some people have ended up with end stage need to be transplanted around dialysis. But in 2015, the drug became available in Canada through Health Canada, and not approved by provincial formularies or public payers, but certainly by private payers. And go here. Okay, so the drug is Tolvaptan or GnRH, which blocks the ability of the cyst to get bigger because it blocks water getting into the cyst. And so it causes people to have a very dilute urine. So that's the mechanism of action of the polycystic kidney treatment, which is the Tolvaptan. And the people that would benefit have been shown in clinical trials to either have very large kidneys or have kidney function is starting to decline, particularly if there's suggestion that you're a type 1 or an earlier onset risk for end-stage kidney disease. And so we put together a couple of recommendation documents a few years ago for the Canadian physician population, the nephrologists and others, to say that Tolvaptan would be, should be considered for people who are between the ages of 18 to 55 with a kidney function between 25 and 65 mils per minute and have large kidneys. If you're over the age of 55, though, we do want to see evidence that you're showing some rapid decline, because it may not be as valuable a treatment in a type 2 ADPKD if you're going to be live into your 70s or 80s or even 90s without needing kidney replacement therapy. So there are criteria out there. In Halifax, there's 2 nephrologists at the QE2, which see the all of the ADPKD patients that are referred for consideration of Tolvaptan therapy. And so you can be referred to the general nephrology pool, and will come to myself or Dr. Penelope Poya. Obviously, high blood pressure needs to be treated, and one of the studies showed that if you're below the age of 50 and with no heart problems, then you would benefit from having a blood pressure a little bit lower than what we would suggest for chronic kidney disease. So 110 on 70 rather than 130 on 80. Pain becomes quite difficult. It could be from kidney stones, it could be from rupture, it could be from infection, and even just the size of the kidneys themselves can cause a dull, achy pain. We've seen people that have somewhere upwards of kidneys that may be 25, 29, 30 centimeters in length compared to a normal kidney, which may range between 7 to 10. So you can imagine just the compression of large kidneys and a large liver causing people to feel quite uncomfortable. And also liver cysts can be quite large and quite painful as well. So depending on how you manage it, you might need anywhere from mild things all the way up to specialized medications, including narcotics for treatment of polycystic kidney disease and pain. I'm just going to close my office tab. 80% of people have liver cysts, and in women with pregnancies, thought to be due to the influence of hormones like estrogen, they become bigger and larger. And sometimes people need to have both a combined liver and kidney transplant, or sometimes just a liver transplant from a very large liver. I'm not going to talk about brain aneurysms. That is a bit of another topic. It's more common in type 2, and there's recommendations around screening. And again, there's lots of material on the website for people to go to and find the answers. And again, a lot of the questions that people have can be answered by going and finding what's been put on the website, the PKD website. So again, I've said before that as we start out, the kidney grows over time with more and more cysts. And as the kidney starts growing and crowding out the normal tissue, the kidney function starts declining. And this was shown by blood tests, and it's also shown by the symptoms people start getting. And so when we talk about when the kidneys are no longer working, we talk about kidney replacement therapy, so dialysis, and also kidney transplantation as well. And as Brenda had mentioned before, you can get a kidney from a deceased donor, or you can get a kidney from a living donor. So I'm not going to go over this in great detail. There's hemodialysis, which is the machine. There's also the peritoneal dialysis, which is the fluid into the abdomen. And there's lots of options for even hemodialysis. You can do it at home, or you can do it daily, you can do it at night. And peritoneal dialysis can be done with exchanges, or it can be done overnight with a machine called automated peritoneal dialysis. And then obviously kidney transplant. We would like to do preemptive transplants if we can identify a donor. In the MOTP program, or the multi-organ transplant program of the Atlantic Canada, it covers all 4 provinces. You can refer people initially when their kidney functions around 15%, realizing that most people do not start dialysis until they're around 6 to 8%. And then if you do not have a living related donor, they really don't start doing a workup on you until you're close to 11%. And that's really because if your kidney function is not declining rapidly, a lot of the workup that you do for kidney transplant have to be repeated on a yearly or annual basis. And therefore, if you're starting too early, you're just repeating. And again, the other thing that has happened in Atlantic Canada with presumed consent, then there are many more donors coming forward, deceased donors. And we've also been doing some work on trying to increase living-related donor transplantation as well. And again, resources are available. There are Canadian transplant resources. There are things everywhere you can go and look them up around other information. Here's the one for Atlantic Canada, motpatlantic.ca. We've had an incredibly busy last couple of years. Last year, usually we do 70 or 80 transplants. Last year, there was 120. And already this year, we are close to 100 transplants by the end of August, going into September. And it just seems to have taken off, which is a wonderful thing. The wait list for kidney transplant has really dropped significantly in the MOTP program in Atlantic Canada because of the numbers of donors that are coming through. And here's some more information for people to look up and questions that could be answered there as well. So the summary here is we talked about getting a diagnosis by ultrasound or CT or MRI. We talked a little bit about genetic testing, generally not indicated, but certain areas would require genetic testing. We can do other things to look at, what is your prognosis? who should be considered for Tolvaptan, how do we optimize your treatment, and then all the non-targeted treatment things like controlling your blood pressure, salt restriction, keeping your weight off, being active, all that other healthy stuff you're supposed to do. And that comes from the publication that we did back in 2018. I was the main author to bring a group from across Canada to talk about what the recommendations should be. Future research continues. We're looking at both mechanisms, new treatments. I've talked about it, less extensive genetic testing. There's been a lot of interest in low caloric or ketogenic diets. High phosphate and oxalates are not beneficial. There's been a group of people in Toronto who were looking at doing foam sclerotherapy. So they go into big kidney cysts. They'll take the fluid out. They'll inject some foam, which scars it down. And you can imagine if you had a 10-centimeter kidney on the top of your kidney, to have that shrunk down so you got rid of that bulk would be completely wonderful. Not ready for prime time, though, still under investigation in Ontario. It's been unclear about the SGLT2 inhibitors. There seems to be some data now that suggests it might be helpful, because this drug has been found to be so kidney and cardiac protective for all the other forms of chronic kidney disease out there. And then people are looking at, drugs that are used for diabetes like metformin and repurposing them to be used in polycystic kidney disease as well. So the march towards getting more definitive cure, better cures, combination cure therapy still continues with lots of energy and vigor across the world. So I am going to stop there and leave it open for the next part.
Thank you so much, Dr. Soroka. It's really good to have a reminder for some people who may already know some of these things, or for people who are new to PKD to have an introduction to what you need to know and where you need to find out the answers. We do have a few people who are attending the call live. Does anyone have any questions? I see that there's one so far. What is the name of the other doctor that Dr. Soroka mentioned at the QE2?
Okay, so that's Dr. Penelope Poya is her name. She's been in the group for probably maybe up to 15 years or so.
Okay. Not seeing any other questions in the chat. So if you feel like if there is a question that's come up that you would love to have answered today, please feel free. There's Brenda. I was just going to say to Brenda, if she would like to come back. If anyone has any questions for Brenda, we'd also entertain those as well. And Brenda, is there anything, since Dr. Soroka has given his presentation, was there anything that you wanted to add from your own experience to anything that he talked about?
I was on the Tolvaptan, but I was in the category just on the threshold of not really being a good candidate for it. But I did take it for a couple of years, and I think it made some difference, but not enough. I'm quite interested, and I've gone to a conference in Montreal there was a doctor speaking about the different things that they're looking at in terms of drugs. And Dr. Soroka mentioned, I think there's the SGLT2I, is that Ozempic, Dr. Soroka? Is that one of those? Yeah. And so there's no clear stats on that as something workable. Do you know if they're looking at it with people that have done transplants? So say I wanted to lose weight. Could I take Ozempic and then at the same time possibly have some benefit?
Yeah, it's hard to know. I mean, I just saw something recently, and the reason why we don't know is that people with PKD were excluded from those trials when they were doing them, because they were mainly for diabetics. Because if we look at them, the Ozempics and the SGLT2 inhibitors are not, it's not Ozempic. Those are the GLP-1 receptor antagonists. So the SGLT2 are the Forgiza and the dapagliflozin, canagliflozin, those sorts of things. So they were originally developed for A1C lowering, and they're fine, but they they were found to be cardiac protective, first of all. So the cardiac trials showed great benefit predicting cardiovascular outcomes like sudden cardiac death, MI, stroke, and all that. And then they found some secondary kidney benefits. So then they galloped off and did all these kidney trials as kidneys are the primary outcome, and they were incredibly powerful. So you need to treat like 10 people for 3 years to show that you can reduce an event. So incredibly powerful. And so they are kind of the standard of care now. And then the GLP-1 receptors, which is the Ozempic that you're talking about, was again, it's the weight loss one, but now the studies are both showing cardiovascular protection and kidney protection. But again, you know, so again, when you do the study, it's like, well, you know, it's like the Tolvaptan, it's for the population you study, the benefit. And so the rest of the people that you might think about are kind of off label. And so you're kind of wondering, because even the SGLT2 inhibitors were never studied in type 1 diabetics, but now they're doing the studies. So you have to actually take a transplant population and randomize them to, you know, Ozempic versus not, or SGLT2 inhibitor or not, and then show that there was a benefit in the people that got the active drug. So I think
might be a ways away, and it's certainly not, doesn't sound like it's centered to transplant talk. It's more about renal failure discussion, not the transplant world.
Yes, but remember, if you know, your transplant, you know, again, has the same risk, not because of PKD, but from everything else, just of normal aging, that, you know, if we can extend the life of your transplant longer by certain agents, it would be wonderful too, right?
Yes.
Because as you know, as we know, depending on multiple factors, you can come out of a transplant and your kidney function could only be 30, 40, 50%, not 90 or 100. And, you know, and you know, transplant is wonderful if it works, but if it doesn't, it can be even worse than being on dialysis. There's multiple people that can attest to that as well. So,
Thanks for that.
Thank you. We do have another question I see here. I think this is for Dr. Soroka. Have you seen anecdotally the difference in progression of PKD when patients are on Jynarque? Like, does it, in your experience, is it helping patients?
Right. So it's a difficult question to answer, because in the studies that were done, when they took people that were getting the Jynarque and people that were not getting the Jynarque, the people getting the Jynarque did not have their like, let's talk about their eGFR. So the eGFR was declining at about 3 or 4% per year. And then the people that got the Jynarque slowed their progression down to 2. So they actually, they were still having declining kidney function, but at a slower rate. And when you talk about the growth, from all the studies that have been done, including cohorts where they follow them over time, everyone has their own growth curve. And so when I start people on Jynarque, I say, you know, to do an ultrasound or an MRI or something 2, 3, 4 years later, I can't really tell what the benefit has been, because if I could treat your left kidney with Jynarque and not your right kidney, and your right kidney grew by 5 centimeters and your left grew by 1 centimeter, I can say, oh, it's working, look at it, brilliant, right? Can't do that. And I can't also look at your split GFR and say, I'm treating your left kidney and your GFR is dropping at 1% per year, which is normal aging, and your left kidney is dropping at 4% per year, which is more in line with chronic kidney disease. So it's really tough to do that. But if you model that out and you say, on average, I'm slowing you down, then how many months or years might I delay your need to start dialysis or get a transplant? And some of the modeling studies have suggested 5, 10, 15 years, right? So that's really the same thing with the diabetes, because we know with diabetes, you start declining at an accelerated rate. You put the SGLT2 into the picture, and all of a sudden it starts flattening out the slope of the decline. And then I bought you years off of needing to start dialysis. So that's the real benefit of them. It's not going to completely cure anything, but it's going to slow down your decline towards kidney replacement therapy.
Thanks so much. I'll ask one more question before we finish today. With regards to research, I know that one of the things that's been so important to our community, the PKD Foundation of Canada, and in our fundraising efforts is this idea of trying to find a cure for PKD so that people don't have to have PKD in the future. in your experience or opinion, what would need to happen to find a cure for PKD? Like, where would they eventually find something like that? Like, what processes may need to be altered or interrupted, or?
Right. So, because it's a genetic mutation that causes ADPKD, and because the gene is such a big gene, you'd say the ultimate therapy might be to do some genetic manipulation to change the gene. And how far away might we be from that? I don't know. There's been all kinds of things where they'll take a virus vector, so they'll take a virus and they'll put some sort of enzyme into it, and they put it into you, and it targets a cell, and it goes and changes your DNA, your mRNA, which makes which makes proteins and all that sort of stuff. But to date, what they've been working on is just things that interrupt pathways that are downstream effects of having the gene mutation, like the tolvaptan, and like the other things, like they were looking at some of the immunosuppressive therapy drugs that, like tacrolimus and stuff like that, or rapamycin, that didn't really show benefit in clinical trials. And even these things like metformin that are used commonly in diabetes work on some metabolic pathways that may change the progression of disease. But again, the treatment is giving you a kidney that doesn't have the gene in it, and therefore you have a normal kidney that's not going to develop cysts and then have the same fate as your normal kidneys. But again, the other parts of the body that have the genetic abnormality are still going to be there, so you're at risk of diverticular disease and all the other things. So it's a really interesting question about how you would do that. I mean, if we could genetically engineer you to be the perfect human from conception, and you had no bad genes when you were conceived, then that's the way to go, right? But let's see. They've been trying to build an artificial kidney for at least the last 35 years, and they still are not there yet, even though they've got some really amazing things with nanotechnology and all these really cool things they're doing, but we're still not prime time yet.
We'll now move on to our patient story today, and a reminder that during the original live event, this section of the presentation was first, before Dr. Soroka's presentation. Brenda MacKenzie is a PKD patient and kidney transplant recipient who co-founded the Halifax chapter of the PKD Foundation of Canada and the Halifax Walk to End PKD. She's a valued PKD ambassador and kidney transplant advocate. Here's Brenda's story.
I can't see who's on the call from my end. I don't know how many people are here. And I don't have any idea of sort of the background of the people that I'm speaking with, other than all of us have a commonality, and that we have a chronic condition of kidney disease. I'm really pleased to be here, and I feel quite knowledgeable about the topic. I'm 64 years old, and in my family, we have a long history of polycystic kidney disease. It's genetic from my mother. And I do want to share a story. I'm not sure my story is any more remarkable than anyone else's who's on the call. And as I was preparing, I had sort of set notes, and I'm going to go to those. But I guess I got thinking about the fact that what is it that I would want to hear from a patient? I was asking myself, what do I think is important that people might want to hear from a patient? And the more I kind of got stuck on that word patient, because that is what we're identified as in the healthcare system. But I guess I want to challenge all of us to think outside that, because yes, we are considered a patient, but the reality is we're people with a chronic disease or family with a chronic disease. And, it's a struggle. And just like everyone out there, everyone has their genetic predisposition to some kind of illness in their family, whether it's cancer, no matter what it is. And so I think the biggest thing that we all have to deal with is, how are we going to deal with our disease? What is going to be our mindset? How are we going to perceive ourselves? How are we going to go forward and deal with the challenges that come with it? And I decided early on that I was going to be one of those people that was going to be vocal. So I knew early that I had the disease. I just was discovered when I was 39. I was diagnosed, and again, I'm 64 now, so there's that journey there. And I knew that what I wanted to do is I wanted to be outspoken about it. I wanted to educate people. I wanted to be involved. I wanted to be involved in my own care. I wanted to have a voice. So that was my mindset. And I realized that not everyone, I don't know, maybe as feel proactive about that kind of thing as I do, but that was my kind of plan and my decision that I was going to go down that road. And I'm not sorry that I did that. I mean, I'm a real estate agent. I've been doing real estate for 37 years. And I know that when I went public and told people and shared my situation, I probably lost business. But you know what? That's just the way it goes. Sometimes you have to make a choice, and you can be sort of closeted about an illness, or you can be upfront and open. And I did decide to be open. And that's why it's important to me to be on this call today. And it's important to me to be part of kidney disease and the work that goes into it ongoing. So I'm a patient. I'm a person with a chronic disease. I'm a sister to a brother, and I see my brother's on the call, Gary, who also has a disease. And actually, there's some pictures here I just want to show you, because this is my mother with the hat on, and she's an amazing woman. And I'm going to talk about her history, and I'm going to talk. There's my parents, my mother and father. The strangest thing is my father passed away in June, and of all the things that he could have had as a condition, he passed away with kidney disease, kidney failure. And so that was totally unexpected. I mean, my father had some illness, but kidney disease was not. I mean, we were the ones with kidney disease, my brother, myself, my mother. So for my father to pass from kidney disease or kidney failure was a bit of a shock, but a full circle moment in the history of the MacKenzie family. So I was a caregiver to my mother and a daughter, obviously, to two parents who both ended up with kidney disease. There's a picture there of my brother, Gary. I hope you don't mind, but I'm putting your picture up there, and you're going to say, why did you put that one? But anyway, this is my brother, Gary. He was living in Windsor, and Gary found out that at the age of in his mid 50s that he also had polycystic kidney disease. And he had quite a journey with it as well. So I'm going to tell you a little bit about that history, but I'm still sharing the fact that the story goes deep, in that I'm a sister, a daughter, a person with kidney disease myself, a caregiver, and I feel I'm a volunteer. I'm part of the KPAC, which is the Kidney Patient Advisory Council, and I'm an advocate. I'm an advocate for education and discussions, open discussion and dialogue with people who are going through the challenges of facing the fact that they are going on dialysis. I like to be part of education for nurses, and I'll share a little bit about that when I talk about KPAC further on in our discussion, or I guess my discussion. Anyway, if you could just go to the next slide there. Okay, so this is me, and this is me, a picture I took in the chair on dialysis. So my history goes back. My mother was diagnosed with kidney disease at an early age of 39. She first had an aneurysm, a brain aneurysm, and we did not know, but there is a connection between an aneurysm and kidney failure. So my mother, unfortunately, did have a brain aneurysm when I was 8 years old, and she would have been 39 at the time, or 37 at the time. And so luckily we got through that. Mom got through her aneurysm. It was not a pleasant situation, but she came through the other side, and it was, she did amazingly well. So a year or two after that, we discovered, it's a little too early for me to be there yet. Sorry about that. So we discovered that Mom had polycystic kidney disease. So they removed her kidneys altogether after she was on dialysis for a year, and she got a transplant in 1970. 1972. So I was 12 years old, and she got a transplant from her sister. So Michelle, if you just go a little further in the slide, there's a picture of three beautiful women. And there they are there to the right. So my Aunt Marilyn is the lady on the far left. The picture of the woman in the middle is my other Aunt Bev. And the picture on the right is Dolores, my mother. So my mother, this is her maybe 6-7 years ago. She's just amazing to me. I mean, she's been through, like I said, the aneurysm. She's had a transplant. She was on, had the transplant for 37 years, and she is now back on dialysis. Unfortunately, her kidney wore out, and Mom is now back in the system as part of having dialysis 3 times a week. She's 93 years old. And at the time that this picture was taken, we were having, I think it was Thanksgiving or Easter or something. And again, that's a picture of her after having 3 treatments a week for 3 hours at a time. And there's her sister now, who's going to be 90 this year on the left. And she is doing extremely well. So was a donor, and my mother had a perfect kidney transplant. And the funny thing is, since my father passed away, my mother now lives with these 2 sisters in their house in Dartmouth. So the middle sister is the youngest, and she is 83, and my aunt that gave the kidney is 90, and my mother's 93. So to me, that is a perfect success story. So the end result has been quite amazing of our journey. Okay. So it's really something that you can all, I mean, I think everyone can look at and feel inspired by the fact that because you get a bad diagnosis, and you are told that you have kidney disease, that you can live a long life. And not everyone can get a transplant, but sometimes Mom has been on dialysis for 15 years, and there's a lot of people that are on dialysis for a long time, and they manage quite well. So the fact that she's getting older, I think, is probably one of the worst parts of it now. So if we can just go back a little bit on the slides there. So yeah, that's dialysis, obviously, and anyone who's on the call, and again, I apologize, I don't know the history of people that are on the call, but if you are on dialysis, you're familiar with the machine, you're familiar with the chair, and you're familiar with what it's like to be on dialysis. We know there's different types. I personally chose to have a line, a central line, and I did that because I wanted a transplant right from day one. I wanted preemptively to have a transplant, and I decided that talking about it and sharing it with people I knew, that perhaps something good might come my way. And I did have a lot of people go in to be tested to give me their kidney. And I think there was 8 people, but unfortunately, none of them were in a position that they could do that. So they all had either their own health issues or reasons why they could not donate. And that was a bit of a roller coaster ride. There's, you're on the waiting list if that's something that you again, aspire to have, and you go on that waiting list, it's a bit of a anxious time because you're waiting for a phone call and you just don't know when it's going to come. And they tell you could, it could come tomorrow, or it could be years. So I did get my call 3 years from almost the day I started. So 3 years after starting dialysis, I was fortunate enough to get a call to have a kidney transplant. But along the way on that journey, I think it's important, again, it's how we manage ourselves, what we're going to choose to do about our condition. Like, how are we going to deal with it? And I thought the best thing to do was to be really ingrained in the process. So I wanted to go to the treatments. I wanted to get to know my nurses. I wanted to understand the machine. I wanted to meet the people that were coming in the room and talk to them in the waiting room. I tried to be as positive and upbeat about it as I could, all while working as a realtor. And it was hard, I got to be honest. But I also decided that while I was sitting in the chair, that I was going to get my broker's license. So for real estate. So I studied for the 3.5 hours. I decided to go nights. So I went on Monday, Wednesday, and Friday nights from 6 o'clock till 9:30. And that schedule worked for me. So I think it's important, again, that you decide what it is that you think is the best option for you when you have your dialysis, and that you embrace it to the best of your ability, because let's face facts, there's not much we can do. This is how it's going to go. And you can either choose to be, woe is me and kind of get swallowed up in that, or you can choose to try to just take a step forward and embrace what you're going to go through. And it made it easier for me. I have to be honest. I don't know what the alternative would have been, because I didn't have it in me to do the alternative. I just went gung ho, and like I said, I decided I wanted to have a transplant, and that was that. So in that whole mental thinking, and that's me with the transplant. So that's the good story, which we'll get to in a minute. But during the whole journey, I decided I wanted to become involved. Okay, so I wanted to advocate for other people. I saw people in the waiting room, and I felt that I don't know, there was just a sadness, and I wanted to inspire and try to help people. So I thought, what could I do? So I met a couple of women that they're on the right-hand side. That's a picture of me holding the proclamation for Polycystic Kidney Disease Awareness Day. So we started the flag raising down at City Hall. And the lady on the right is a good friend, Anita McDonnell. And to the left is Brenda Conway. And so we all have polycystic kidney disease. Brenda is not in a position now that she is on dialysis, but she does have enlarged kidneys, and she has issues from a different point of view with the disease than Anita and I. I met Anita. I want to tell this story because I think it's just goes to show kind of what happens if you're open in who you are and what you're going through. So I went to a coffee shop. It's called Lara's on Agrigula Street in Halifax. And again, I don't know my crowd here if you're from outside of Halifax or not, but Anita was behind me in the lineup, and I knew the barista at the coffee shop, and I said, I'd like to buy a coffee for the lady behind me. So the lady behind me was Anita, and I'd never met her before. And the barista said, oh, it's really great that you two are meeting, my two favorite clients. And we laughed, how you would do. And she said to Anita, Brenda needs a kidney. Maybe you could give her a kidney in relation to I gave her a coffee, she can give me a kidney. Well, Anita said, I need a kidney. And I said, I was in shock. I thought she was kind of joking. And I was like, no, really, I do need a kidney, but whatever. And then she goes, no, but really, I need a kidney. So the two of us just stared at each other. And I said, do you have 15 minutes to sit down and have a chat? And so the two of us sat down to find out that we both needed an O kidney, that I was on dialysis and Anita was going on dialysis that very year, that our mothers back in 1972 were going through their journey with their kidneys, and that they were on dialysis at the same time. Now, the good news story for me was that my mother got the transplant and mom is still alive. And unfortunately, Anita's mother did not. So polycystic kidney disease runs in Anita's family. Everyone in her family, all the kids in her family, they either have kidney disease or they are donors to their siblings who have kidney disease. So if there's any story to be told, the story from Anita would actually blow your mind. But the strangest thing is, again, in just being open and embracing the fact that you walk through the universe and humanity, and you talk to someone and you share, that you open up the possibilities for so many things to happen. And So Anita got her transplant from a living donor, someone that she knew at work. She got it 10 days before me. So I got mine in November 2021. Anita got hers late October. We just missed each other in the hospital. I got my kidney from a person who passed away, unfortunately. So I've got a cadaver kidney. And the two of us, so here we are, it'll be 3 years. We celebrate an anniversary every year where we get together. And it was during that meeting where Anita and I decided we were going to advocate for ourselves and for others, and that we wanted to be part of a chapter, bringing a chapter to Halifax. And so Brenda Conway, the other person that was in the picture, had been part of a chapter before with polycystic kidney disease. And so we reached out to her, and the next thing you knew, we were starting a chapter. So we decided to be co-chairs. So instead of one of us taking it on where we've all had our own illnesses, we decided to do it jointly. And it worked out great. But we did burn ourselves out, I'm going to be honest, in the 3 years. And so we have taken a step back this year. The picture here, which I absolutely hate, anyway, whatever. That picture is a picture of myself with my partner, Simone. Simone has been my partner. We've been together for 25 years. And I'm going to say to you that having a person in your life who is supportive, who understands, and who is with you in your journey is so important. It's important to your well-being, not only when you're going through the challenges of feeling unwell, but to just your everyday life. So, the support that Simone gave me through work, through, when I came home from dialysis, to when I was tired, to my kidney transplant. She was there for me every step of the way. And she was a champion to help me with being the co-chair for the chapter. And what more can I say? Because you can see her smile, and you can her warmth, and just everything that Simone exudes has helped me. So it's really important to have an advocate for you, and to, whether it's a friend, if it can't be one of your family members for whatever the reason, it's just important to have a support group. And I was the most fortunate person that I had that support group. And so just to go to that again, I joined also something called KPAC, okay? And KPAC is called the Kidney Patient Advisory Committee. This committee is just stellar. It's unbelievable. It is about policy, the policies of the hospital, so Nova Scotia Health, and discussing how the renal program can be better, okay? And it's all patients. So the patients that are on this call with one of the key people behind policies for the renal program, her name is Lisa Hoya, and she has been so inviting, and she's picked some wonderful people to be on this call. We are on it every month, and we have made such dynamic changes to the renal program by being voices at the table. So it would be uncommon for us ever to be actually really at the table with the doctors, with nurses, talking about patients and talking about ourselves as people with a chronic illness. And to be able to add to the conversation and advocate for herself and make change has meant the world to me. And I know the change has been positive. So Michelle, maybe you could just, so this, I'm not putting this out here to brag, okay? And you can hardly see it, but it is an award from Nova Scotia Health. And it says Outstanding Patient Family Advisor Award for 2023. And why I bring this, because there's all these committees out there that advise Nova Scotia Health when it comes to different illnesses. So whether it's cancer, kidney, or renal program, whatever it is, there's all these volunteer committees that are behind the scenes that help make Nova Scotia Health go round, okay? The renal program has really made such amazing changes that we were acknowledged. And even though the recipient, they chose me as the recipient, I do not feel, this is on behalf of all the committee. Okay, I accepted it on behalf of the committee because again, I mentioned how much work we put in and the changes we have made. And I just want to talk about a few of them because it may inspire you to go and want to be part of making change and advocating and speaking out. Grateful is what I am, but I'm going to come to that slide last because gratitude, I think, is so important in everything we do. There's a slide that shows some comments from nurses on a little card right there. So messages from staff. So in being part of KPAC, we have made some crucial changes to the program. And I'm looking down because I want to make sure I capture a few of them. So the orientation for nurses has now changed. Okay, so new nurses who come to the renal program as nurses, from now on, they watch a video. It's part of their curriculum. And that video is a video of 4 patients, myself being one of them, where we talk about kidney disease, we talk about how important the nurses are, and we talk about what we would want nurses to know. Because it's so important. We are not, and I started this way, we're not just a patient. We're not just a number. We're not just a person in a system, okay? And we have to help educate nurses that it's not about the machine, because it's been so programmed and ingrained that it's about the machine, the machine. It's not about the machine, it's about the people. And the machine is what helps us and cleanses our system and helps us to get through day by day. But the people that you meet, the nurses, are so important to your well-being, emotionally, physically, and mentally, because I don't know about any of you, but that was something that I struggled with when I first found out I had kidney disease, is the whole mental part of it. How am I going to work? How am I going to keep my income? How am I going to live a life? How am I going to be around my friends? How is this going to affect me as I get more sick? Because I got down to 4% function, and 4% function is not very good. Dr. Soroka's on the call, and he knows. I mean, I fought it. I did not want to go on dialysis, and when I did, and I embraced it, and I went on dialysis, I felt so much better. And that's when I started to change my mindset and decide that I was going to just hug this and move forward with it in as positive a way as I could. Michelle, am I okay for time? Sorry, everyone. I'm just making sure because I can tend to talk a lot.
Sorry, it took me a minute to unmute myself.
Yeah.
If you wanted to wrap up shortly, we might be able to come back
And have
and sort of do some questions at the end. Is that okay? Is there anything else you really wanted to say right now before we bring Dr. Soroka on?
I think the only things I would say is maybe challenge yourself to think about your condition, your disease in a new way, outside the box, instead of just being a patient, which is, I know how this started. I am a PKD patient. That's why I'm on the call, but it's way more than that. So I think other than that, I want to say gratitude. And gratitude was my last slide, is grateful. So my partner Simone made that sign for me. It's in the background. And I'm grateful every day. I feel gratitude. I went through this experience with a feeling of gratitude. And I feel grateful to the system, to the health authority, to the nurses, to the doctors, to my family, to my donor. And that's within me every day. And I think if we can also embrace gratitude and look forward to positivity, then we can make a difference in our own lives. So with that, I'll end.
Thank you so much. Well, I see we've come to the end of our time. I want to thank both Dr. Soroka and Brenda for what they've been able to share with us today. It was really important for us to have someone have something specific to Atlantic Canada as opposed to across the country, so that people had a more of a feeling for what is happening locally and what's possible locally. And I think Brenda really helped explore some of that with her patient advocacy work that she's been doing, and ways that people could get involved themselves if they were interested. So thank you to both of you. We really appreciate it. This event has been recorded, and we'll make the recording available probably within about a week, and we'll share that with everyone who's registered, and we'll also be putting it on our YouTube channel so that the general public can watch it as well. So thank you so much.
Thanks, everyone.
Thank you all.
Thank you.
Bye.